Hi, friends. My name is Whitney Wade. I want to thank you for joining us today for this Global Health Coffee Break. I'm going to turn the opening remarks over to Todd Golub, a Core Institute member and Chief Scientific Officer at the Broad Institute.
Great, thanks, Whitney. Welcome, everyone. I'm Todd Golub, CSO at the Broad, for those of you that I don't know. It's an honor to have the opportunity to open this session. I think we all realize that we're experiencing the collision of two public health crises in our country. The first, obviously, being COVID-19, and the other being racial inequities that translate pretty directly into healthcare disparities. COVID-19 arriving as a surprise, the health disparities really shouldn't be a surprise, but I think it's fair to say that it's newly on the consciousness of many in our community, and these two healthcare public health challenges are now colliding. The Broad Institute feels like a tiny speck on the public health stage, but I think, like in other matters, we're committed to trying to punch above our weight. And so there have been a number of activities in this area that I think are important to mention. First, a year or so ago, we launched the Global Health Initiative to bring ideas and new capabilities to parts of the world that have been underserved by modern genomics research. We have this amazing Shades at Broad community that, among other things, is helping us struggle with how we can make the Broad a more diverse and inclusive community. And these two threads are, coming together in really pretty profound ways. I think this seminar is an example of that. I think most of you are probably aware of the Broad's role in standing up COVID-19 testing, viral testing, but you might not be aware of the way that the Broad has been working to try to ensure that this capability benefits as many people as possible. There's been a very substantial financial investment in equipment making it possible to scale up COVID-19 testing. Now the Genomics platform has a capacity of 35,000 tests per day to make available throughout the area. All of these tests are done at cost with no profit whatsoever for the Broad. And for more than 1,000 people, in particular those living in low-income housing and in homeless shelters, COVID testing has been done at no cost to those individuals. There's also been a big effort to make sure that this Broad testing is available in nursing homes across Massachusetts, where most of those nursing homes are serving low-income individuals as well. And there are ongoing, complicated, but ongoing discussions at the state and city level around how we can make this testing available, in particular to disadvantaged communities who in many ways need it most. So there's a lot to be proud of in this area at the Broad, but there's clearly a lot more that needs to be fixed in our system. I think the COVID-19 pandemic has exposed a lot of challenges with our healthcare system generally that wasn't designed to be nimble in response to a pandemic like this, and certainly has not been optimized for equity in terms of access. But we have to remain committed to doing what we can to maximize the impact of our research and of the testing and other capabilities and ideas that are in our community. So I'm really proud of the Broad Global Health Initiatives and Shade at Broad to put today's discussion together, because I think this is a great start to tackling some really important issues. So with that, I'll turn it back to you, Whitney.
Thank you, Todd. And thank you, everyone, for joining us again. I'm sure we've had a couple of latecomers to the meeting. Again, my name is Whitney Wade, and just to give you guys a little bit of an introduction, I am the operations coordinator for the HAIL team in the Stanley Center, and I also am one of the co-chairs of A4C, which is the African, African American, and Afro-Caribbean subgroup of SHADES. The vision of SHADES is to foster a diverse, inclusive, and collaborative community for the benefit of Brodies of all ethnic backgrounds, and for the advancement and empowerment of the Broad Institute scientific research globally. A4C hopes to build on this vision and enhance the experience of Brodies who are part of the African diaspora by partnering with other Brodies to build community, inclusivity, and a sense of belonging. So I really think that this goes hand in hand with the Global Health Initiative, and I'm very happy to be able to join you here today. As a Black woman from a multiracial family, this topic is very significant personally, and I'm honored to be able to moderate this discussion with our distinguished speakers. Today we have Nancy Krieger, who is the professor of social epidemiology and the director of interdisciplinary concentration on women, gender, and health at the Harvard School of Public Health. We also have Adrianne Gladden-Young, who is the senior viral genomics researcher in the Sabeti lab at the Broad Institute, and the author of the recent Atlantic article, Give Black Scientists a Place in This Fight. And finally, we have Alistair Martin, who is an emergency medical specialist at Massachusetts General Hospital and a teacher in the MGH Center for Social Justice and Health Equity at Harvard Medical School. With that, I will turn it over to Nancy. Thank you, Nancy.
So thank you very much for including me in this event. I'm very glad the Broad is addressing these issues. I'll speak with you briefly in my 15 allotted minutes on structural racism, COVID-19, and the stories bodies tell. I begin, as I do for all my talks, by acknowledging that I, as a US person in Boston, Massachusetts, am on Indigenous lands, and I pay heed to critical Indigenous thinking. And I also speak at a time of great outrage, anguish, and social mobilization over police killings and structural racism. And both of these are profoundly intertwined with COVID-19. My three key points are: first, there are terrible inequities reflecting structural racism and social injustice in who is being exposed to the virus that causes COVID-19 on account of their working and living conditions, and these inequities can be prevented. At issue is who can versus cannot afford to work from home, let alone has a home, and if they do, have the space to self-isolate if infected, and if an essential worker, who does versus does not have safe working conditions or is provided with adequate personal protective equipment. Second, there are terrible inequities in who is more likely to die if infected, given pre-existing health inequities involving cardiovascular disease, diabetes, and excess exposure to pollution. And third, there are terrible problems in how the data are being reported by public health agencies, which makes it hard to see and address these inequities. Remember, as you look at these data for the US, taken from the Hopkins website, which show that regrettably the US leads the world in case and death counts, every tested person, every one of the 2.3 million confirmed cases, has worried about what will happen, as have their families and friends. Every one of the nearly 120,400 people who have died have had families, networks, and neighborhoods who are grieving, translating to millions affected. And only recently, after considerable hue and cry, has the CDC included data on race, ethnicity, and COVID-19, which makes clear this burden is inequitably distributed. The rates of hospitalization and mortality are 3 to 5 times higher among US non-Hispanic Black compared to white persons, and these risks are also higher for other populations of color. Limiting interpretation, the CDC fails to include data on occupation, income, education, disability, sexual orientation or gender identity, or incarceration status. Here I note that the age-specific racial ethnic inequities in COVID-19 mortality, which we have just newly documented, are extraordinarily high among working age adults, on the range of 7 to 9 times higher for the Black, non-Hispanic, and Latinx population compared to the white non-Hispanic population, and indeed higher in just about every age group over 25 for all other racial ethnic groups as well. These cannot be explained away by comorbidities because the rate ratios typically for that would be more on the order of 2 for what are the known racial ethnic inequities. And when you get rate ratios on the order of 7 to 9, something else is going on here called exposure inequitably. So how shall we interpret these racial ethnic inequities? Theory is key. On this slide, I show the overall framework of the EcoSocial Theory of disease distribution, which I first proposed in 1994 and have elaborated since. And I also show its direct application to the analysis of racism and health. Concerned with levels, pathways, and power, and also time in relation to both individual life course and historical generation, EcoSocial theory seeks to explain population distributions of health and health inequities. A central focus is on embodiment, referring to how we literally embody, that is, incorporate biologically, our societal and ecological contexts, thereby producing population patterns of health and health inequities. This theory clarifies that there is not one pathway by which structural racism harms health. There are many, including economic and social deprivation, excess exposure to toxins, hazards, and pathogens, social trauma, health-harming responses to discrimination, targeted marketing of harmful commodities, inadequate medical care, and both ecosystem degradation and alienation from the land, especially but not only for indigenous peoples. The ecosocial constructs of agency and accountability further clarify that racism, not quote unquote race, is causally what's relevant. At issue is who benefits from, not just who is harmed by structural racism, noting that in the US, white settlers imposed enslavement on both captured Africans and indigenous peoples. This tracing of causal arrows from racism to embodying injustice to health inequities is thus diametrically opposed to the dominant view, which draws the arrows from race, quote unquote, construed as biologically distinct groups, to racial differences in health status and culture with no reference whatsoever to injustice. Reckoning with health inequities requires reckoning with embodied histories. As to the value of grappling with embodiment, consider the words of Claudia Rankine, an African-American poet who in her award-winning recent prose poem titled Citizen, an American Lyric, wrote, quote, "The world is wrong. You can't put the past behind you. It's buried in you. It's turned your flesh into its own cupboard. Not everything remembered is useful, but it all comes from the world to be stored in you," end quote. The image from a New Zealand Māori presentation on historical intergenerational trauma tells a similar story, literally rooted in settler colonialism and racism, with the trunk containing the political and social mechanisms at play, and the branches and leaves expressing the resultant adverse outcomes, including but not limited to health status. Roots also are key to endurance and growth, and new Indigenous and African American histories and activism emphasize renewal, continued resistance, resilience, and strength in the face of daunting odds, drawing on history to imagine and advocate for a more equitable and sustainable world. It is essential to be clear that COVID-19 already hit a world riven by inequities. This slide shows all too familiar data which critically situate the context of the COVID-19 pandemic. We live in a world of growing social spatial polarization with ever greater concentrations of private wealth, as epitomized by the factoid that in 2018, 26 persons in the world owned as much wealth as the poorest half of humanity, down from 43 in 2017. In the US, where the top 1% owns a greater share of the wealth than their 1% counterparts in various European countries, 3 men now own as much wealth as the bottom 50% of the US population. Enormous wealth gaps by race ethnicity are on the rise, and intergenerational economic mobility is on the skids. And at the bottom of the slide, consider these data from the new weekly US Census Household Pulse Survey, designed to measure the economic, social, and health impacts of COVID-19. Both before and after COVID-19 hit, that is, looking at mid-March and the beginning of June, among households with children, Black and Latinx households were between 2 and 3.5 times more likely than white non-Hispanic households to report they sometimes or often did not have enough food to eat. Added to which, in early June, among renters, Black and Latinx households were twice as likely as white non-Hispanics to say they had no confidence or only slight confidence that they could pay their rent. But you will not find data on COVID-19 and socioeconomic position, and barely any on race ethnicity in US health agency reports. Instead, most of the US data on COVID-19 and health inequities is being generated by journalists, as shown by this pastiche of articles I've been collecting since the start of the pandemic, reminiscent of how the Guardian newspaper counted in 2015 to 2016 to tally police killings in the US given fundamentally flawed official data, with my research team showing that half of the deaths are not counted in US vital statistics. It was journalists with The Atlantic who set up the COVID-19 tracker, including a quote unquote race tracker, to augment the data not being reported by the CDC. The New York Times and the Washington Post have been leading with data visualizations about the social and spatial distributions of COVID-19 in the US. And as remarked by an historian colleague when she saw this map at the bottom center of my slide that was in the New York Times regarding chronic disease and COVID-19 susceptibility, quote, aside from West Virginia, it looks like a map of slaveholding in 1861, quote, or I would add this recently updated map of US lynchings. And this dovetailed with my quoted remarks on the long histories of inequities that underlie the COVID-19 exposure, infection, and death. Presently, investigative journalists, op-eds, and commentaries have led the way in linking the scant data on COVID-19 inequities, more anecdote than evidence, to the stories of how people live, work, and die, making intelligible that the risks are structural, not personal, and require policies and resources for prevention and mitigation. They are exposing why COVID-19 deaths are highest among social groups with histories of enslavement and settler colonialism, plus pleasant realities of racial and economic injustice. And these are people disproportionately represented among the essential workers and low-wage jobs, typically without sick pay, undocumented workers, including farm workers and construction workers, also people who are incarcerated, and also those exposed adversely to air pollution and environmental racism. After all, if the utilities shut off water because of late payment, you can't wash your hands. And if you live in a crowded household or rely on crowded shelters, you can't easily self-isolate if sick. The stories of structural injustice are vital to contesting the long-standing script stemming from societal and scientific racism that has repeatedly justified inequities by claiming they are due to biological and cultural inferiority, rather than the privations imposed by the privileged to protect their wealth and status. With this background in mind, let me start with the results of the study we did in April on COVID-19 mortality in collaboration with the Boston Globe. We did this study because for COVID-19 deaths, racial ethnic data are incomplete. That's gradually changing now, and no socioeconomic data are included at all, despite death certificates routinely including data on not only race, ethnicity, but also education and occupation. Plus, they also routinely collect data on residential address, including people's zip codes, allowing description of residential, social, and economic context. To get around this problem, we did a study, the first of its kind in the US, working with the Boston Globe. We were able to get the Massachusetts death records for 2020 through mid-April. We then compared the total mortality rate, that is the number of deaths per 100,000 persons per 2-week period, to the mortality rate for the same 2-week period based on the average for the past 5 years from 2015 to 2019. The value of this approach is that it captures all the excess deaths, both those categorized as COVID-19 and those should have been contributed to COVID-19 but were misclassified, along with deaths due to the pandemic but that are not due to the infection. For example, deaths due to heart attacks among people who avoided going to the hospital because they were fearful of infection. And this approach also takes into account the background seasonal fluctuations and causes of death. It also focuses on rates, not counts, since the latter are really not useful absent any reference to population size, even though they're a preoccupation of what is routinely recorded on a day-to-day basis. Using this approach, we computed and compared these rates for 2020 versus 2015 to 19 for every city and town in Massachusetts and also every zip code, which we characterized in relation to their social and economic composition. We used 4 measures, 3 of which I show here: percent of persons below poverty, percent of crowded households, percent of population of color, and the 4th measure pertained to racialized economic segregation. For each measure, we show the graphs that give the 2020 mortality rates by 2-week period on one side, and on the other side shows the mortality rates, which are much flatter, for the 2015 to 2019. Each line represents a different social group, from low to high poverty, low to high household crowding, low to high percent populations of color. Of note, household crowding is directly related to risk of infection and also inability to isolate at home, and is itself a consequence of lack of access to affordable housing and lack of access to a living wage. Moreover, racial ethnic composition reflects long histories of redlining and other forms of racial discrimination, and is also tied to, as I said before, to inequitable exposure to air pollution and environmental hazards. All 3 measures show the same terrible facts, that the death rates surge much higher among communities that bear the brunt of racial, ethnic, and economic injustice. While this might not be surprising, it's still essential to document, as it's critical evidence needed to inform policies about neighborhoods, workplaces, and the routes that connect them. At issue is workplace safety, siting of testing sites, and community provision of PPE and facilities for self-isolation, plus linking to other health equity issues. And just to underscore, it's not as if these patterns are unique to Massachusetts. Here are results of the first study we did, also the first of its kind, whereby we analyzed the death rates solely for COVID-19 deaths for all US counties in relation to these same social metrics. As you can see, the highest death rates for COVID-19 occurred in counties with the highest crowding, the highest poverty rates, and the highest proportions of people of color. These are systemic problems structured by social injustice. Let me close with one last example of how a failure to contextualize racial ethnic data distorts analysis of COVID-19 inequities. Although the majority of US states and territories now report COVID-19 data by race, at least for deaths, often the data are missing. Consider these data on COVID-19 cases from our own state, Massachusetts. Fully 35% of cases as of June 22nd are missing data on race ethnicity. Moreover, no data are provided on the racial ethnic composition of the state's population in this report that's provided on the website, making it impossible to see if any groups are over or underrepresented compared to the total population. By contrast, look at the data that's being reported in Washington state. While they also are missing 27% on race ethnicity, as of June 21st, nevertheless, their website clearly shows how the racial ethnic composition of the COVID-19 cases compares to the state's racial ethnic composition and reveals the excess risk for the Latinx population. While comparisons of rates would be even better, this is a major improvement. It is possible to do better. And while Boston does better when it comes to missing data on race ethnicity, missing only for 3.2% of the COVID-19 deaths, still no data are provided on the website to see how the racial composition of these deaths compares to that of the city as a whole. You have to go to another website entirely. Yet the Seattle County manages to do well in its data dashboard. Its data dashboard allows you to see the data not only for the total population, but also to exclude deaths in nursing homes, which gives a glimpse of what is going on in the non-institutional and working age population. And what you can see here is that while there was some evidence of white non-Hispanics overrepresented in the total deaths, when you exclude the nursing homes, they are underrepresented, and instead the overrepresentation of the Latinx population becomes visible. This is crucial information for prevention and mitigation. Again, it is possible to do better in showing the data stories. To start wrapping up on this slide, I list 3 key steps for action. First, to get better data with the intent of doing a better job with. Second, preventing transmission. And third, developing and implementing apt economic, social, and health policies. On data, the new US requirements issued on June 4th to report testing data in relation to race, ethnicity, as well as sex and gender and age are only a tiny start, since there's no socioeconomic data, and there's also silence about mortality data. Using a health equity lens to contextualize people's individual stories and to illuminate the socially structured constraints that limit people's ability to stay safe and which must be addressed is crucial. To prevent inequities, it is potential to prevent inequities in exposure first and foremost, that is primary, and it is distinct what needs to be done to reduce mortality inequities tied to pre-existing health inequities. It's doable here and now by our employers being mandated to provide PPE and paid sick leave, augmented by government sightings of testing sites, provision of PPE, and safe places to self-isolate in communities in need. It is also crucial to mitigate the social and economic harms of the lockdown, which are disproportionately burden families of color, especially those with low incomes. Vital action is essential to prevent the inequitable suffering now bound up with COVID-19. In closing, we live and die embodied. It is long past time for our sciences to integrate levels and timescales of embodiment from structural injustice to submolecular levels across historical generations with an eye towards revealing what it means to embody dignity, equity, and joy. Let us do our work, including for COVID-19 and health justice, informed by history and a vision premised on social justice and human rights, along with deep recognition of our interconnection with and dependence on our wondrous and threatened planets. And may George Floyd, Ahmaud Arbery, Breonna Taylor, and so many more whose lives are cut short by police justice, violence, rest, and justice, and may the families and friends of all who have died from COVID-19 join with them in grief and with the energy of youth rising up for a more equitable and sustainable future, help prepare this world. Thank you. And these are available if people would like these resources. I can share them later.
Thank you, Nancy. With that, we'll turn it over to Adrianne so that she can provide her perspective as a Brody and a COVID-19 scientist.
Yeah, wow. Thank you for that. And thank you to the organizers for the opportunity to participate in this important discussion about the health disparities that have always existed in the Black community, but that are now more visible as they're related to COVID-19. I'm very fortunate to be able to offer my perspective as a member of the research community that's helped to lead the response to this pandemic in our local area, and as a member of the Black community, which has been so disproportionately affected by COVID-19. And I recognize that, you know, I'm uniquely positioned as a member of both communities to try to contribute in a meaningful way in helping to combat this deadly disease. But what I've come to realize is that you know, the health disparities that we're seeing exist because there's been an imbalance in power and a lack of visibility. We in the Black community, we noticed early on just how severely we were impacted by this virus and disease. And that was long before the statistics were made public. We had many family members and friends, community members who were getting sick and dying because of COVID-19. And at the same time, I started recognizing or noticing that there was a lack of focus on this extremely vulnerable population. And I started to realize just how voiceless and invisible the Black community has been to the agencies that are supposed to be fighting this pandemic on our behalf. You know, our neighborhoods have been overlooked. We haven't received much guidance. People have been denied testing, and overall just haven't been protected as we should have been. And, you know, now we see the data. Most of us, we know the stats. You know, more than 115,000 Americans have died from complications of COVID-19, and 25% of them are Black. But what has been missed is the number of Black people, some with symptoms and some without, who couldn't get tested and ended up spreading the virus in their community. What can't be quantified are the communities of people that will die because they can't benefit from our COVID research because they've been excluded from it. And, you know, there's no way to put a number on the lives that could have been saved had just a fraction of them been given the care and the attention that they needed. You know, what I've seen during this pandemic is that there's a lack of partnership with the Black community, and there's this idea that, you know, the medical and research and public health agencies get to determine what's most important and whose lives should be saved and what should be prioritized, you know, to stop this pandemic. But why? You know, this hasn't benefited the most vulnerable populations, which certainly include Black people. We might not be able to do anything about the social inequities that have caused problems for the Black community, you know, historically. You know, but I hope we can recognize that communities, and more specifically Black communities, are capable of assessing and communicating our needs. And, you know, I'm hopeful because, you know, we're starting to have the right conversations, but I hope that we as researchers and healthcare providers will continue to make the most of this opportunity to develop a more community-led response and true partnerships and alliances where we acknowledge that it's our job to listen to the voices of the Black community and to hear the concerns and needs of the communities that we serve, and then use our expertise and the tools that we have to address these concerns and meet the needs.
Thank you, Adrianne. And now, Alister, you can take it away.
Thank you.
Thank you, Adrianne. I am starting my video now. My name's Dr. Alistair Martin. I'm an ER physician. And in the time I have with you, I'm going to share some stories about what being an ER physician during COVID has been like, but also want to touch on where we are as a country. And I'll start by saying that COVID has really been an unprecedented crisis for our country. The inordinate death that it's caused, the disproportionate rate of death in Black and brown communities, the near halting of our economy for several months, the hopeful but likely long lasting road to a vaccine and other treatments that have sort of left us in this weird limbo that we're all living in. It's clear to me that this is a crisis unparalleled. It's also a doorway to an opportunity. In the time that it will take me to address all of you today, 6 Americans will have died from COVID-19. The majority of those people will be people of color. Now is our opportunity to address healthcare disparities. Now is the time to make the country understand that George Floyd was not only murdered by the weight of 3 bodies pressing down on him, it was the collective weight of history, of oppression, and of slavery, and the racial ordering of humans and goods it established, which constructed a political economy predicated on devaluing Black labor, demeaning Black bodies, and denying Black humanity. Now is the time and the opportunity to say thank you for your Black Lives Matter email, corporate America, academia. Now please show us the pictures of your executive committee and your board of trustees to help us understand how your words translate into the actions that distribute power to create fundamental changes. Now is the time to mobilize non-optical allyship and to demonstrate, not tell, that Black Lives Matter. You see, COVID has forced a great reckoning in this country, and it is our doorway to opportunity. I believe that. But it's not enough to identify a doorway if we do not walk through it. And that's the chance, that's the opportunity, the moment that we have here with COVID. To be a Black ER doctor during COVID is like trying to walk a tightrope in the middle of a hurricane. We are at once witness to the carnage of this global pandemic that we were ill prepared for. And at the same time, we see the expression of underlying injustices and pre-existing legacies of racism on so many different levels. First, on the individual level. I remember at the beginning of this pandemic, we had, and it wasn't just my hospital, this is every single hospital across the country, we had such strict protocols with regard to testing that no one could get tested. And I'll tell you some specifics. For weeks, our testing protocol to use our 20 tests that we had per day, 20 tests, was, has the patient come back from South Korea, China, or Italy? Well, when you're thinking about the working class Black and brown families who work and live in Boston, in Dorchester, in Roxbury, a lot of those folks were not screening positive for meeting our testing criteria. And thus many, just on my shifts alone, I would say dozens of patients got turned away who I knew had COVID. They knew they had COVID, and we couldn't test them and identify whether or not they truly did or did not. Another example is with regard to the individual level of who can and can't quarantine. I remember just maybe about a month and a half ago now, I had a young woman who was in her early 20s who had 2 children, came in with COVID symptoms. And luckily at that time, we were able finally to have testing available, and she was COVID positive. And I told her, look, unfortunately, you have COVID. And so what that means is that for the next 14 days, you really have to take good care of yourself, eat well, drink well, but self-isolate. And what that means is you really have to, set up a space away from everybody else for the next 14 days so you don't transmit this. And she said to me, doctor, what does that mean to self-isolate? I live in a 1-bedroom apartment with my elderly mother and my 2 kids who I take care of. She lived in a multi-generational home, and for her, quarantine was just not possible. And as Adrianne mentioned, what that means is that it's not just her who gets COVID. It's also her mother, who would likely come back weeks later, and because she's elderly, ends up being the kind of person who likely requires a ventilator or some other aggressive therapy. But it's not just on the individual patient level, it's also on the systemic level. It was the peak of COVID when this story that I'm about to tell you happened. It was April 4th, and that week had been a particularly bad week at my hospital and at hospitals all across the country. We were seeing disproportionate numbers of Black and brown patients coming in. Just for example, in our hospital, 50% nearly of all the patients who were admitted to the hospital were Hispanic or African American. The average population of our hospital, our census, is not 50%. It's more like, somewhere between 17 to 20%. And so I was in this faculty meeting with 50 other physicians, and someone was coming from outside of our department to tell us something about a new protocol we'd have to initiate called Crisis Standards of Care. What this means is that we were worried as a hospital system and as a hospital that we were going to run out of ventilators to keep people alive after they stop breathing. And so the crisis standards of care would be our new sort of rules of the road for who gets a ventilator and who does not. The person who was presenting essentially said, look, if folks have a history of chronic diseases, things like diabetes, lung disease, heart disease, this gives them points. And these points count against them. The more points you have, the less likely you are to get a ventilator. And so I made the point that this is, in our faculty meeting, incredibly unfair and unjust. These diseases, things like diabetes, heart disease, lung disease, are all found at disproportionately higher rates in the Black and brown community. And so what we were seeing here was a disease that was disproportionately already impacting patients of color. And now we are going to add a criteria that says for patients who are already impacted by this, let's reduce the likelihood that they get a ventilator. That's systemic racism, if you're looking for an example. That's institutional racism. And so you might be asking yourself, well, why is it that Black and brown folks have higher rates of these diseases in the first place? Isn't it just their fault that they have these diseases? Well, let's go into it. The legacies of segregation and white flight mean that Black people are more likely to live in food deserts, predisposing them to diabetes. The legacies of gentrification and environmental racism increase their exposure to toxins and pollutants, increasing their risk of lung disease. The legacies of redlining and local zoning ordinances limit their access to primary care doctors that can treat and manage their hypertension, increasing their likelihood of developing heart disease. I raised those points, and basically the presenter said, look, great question, hard question, next question. She had no answer. In effect, this was now the state policy. And so, long story short, I was part of a group of physicians, over 100 physicians, who mobilized and organized together to try and push back against these guidelines, these crisis standard of care state guidelines that would disproportionately impact communities of color. We cobbled together a team, first starting with a bioethicist from Harvard named Joanne, who helped create an alternative bioethical strategy that did not disproportionately impact communities of color. We worked with a legislative director who helped draft a press release containing a letter that was circulated around Boston that got over 1,000 signatures by physicians pushing back on the crisis standards of care guideline. Worked with a Senate policy advisor who organized the Black and Latino caucus to write a letter directly to the governor. We started a social media campaign. I have no idea about how to use social media, but we started a social media campaign. I learned, and we were able to get some prominent lawmakers like Representative Joe Kennedy and Ayanna Pressley to put out statements against the guideline. And by April 20th, 16 days later, the state reversed course and revised the policy based on some of our group's advocacy and a bunch of other groups who were involved in this. Now, while that's a story of what is possible because of organizing, it's also a story of what is possible because of power. And you see the most important expression of power and how we, as I alluded to earlier, identify and then walk through that doorway of opportunity is our vote, our most important civic duty. And I work with a growing team, rapidly growing team of physicians, social workers, students across the country who are working to make it easier for patients to vote. As many of you know, 50 million people in this country are not registered to vote. But when you ask people, well, what's the most important policy or sort of policy domain that you care about, everyone uniformly, most people say health policy. And so you have this paradox. 50 million people in this country are not part of the conversation. And nearly everyone says healthcare and health policy is the most important piece of policy in our country today. And so this work called Vote ER is just one manifestation of how we give people their power back, how we help them vote. And yeah, we got an important election coming up in November, but it supersedes November. Folks should have access to the vote and be able to vote in a way that's safe and healthy, by the way, because of COVID. So I'm going to play a video for you all to give you some background in terms of what this work is, and then I'll summarize with a 30-second close. So let me go ahead and share this video here.
Yeah, I wish I could tell you that was my one story about that one time I saw a child mutilated by bullets, or that time I cared for a family so hungry they came to the emergency department simply for food, or that one time where I couldn't discharge a child home simply because there was no home for them to go to. See, it's not just one story, and it's just one time. There's just far too many to count.
And COVID-19 is just exposing how broken our healthcare system is. I remember at the beginning of the pandemic, we had patients desperately asking to be tested. My response, I just didn't have any tests to send. I remember one patient asked me, well, doctor, how is that fair? I just saw the entire Brooklyn Nets got tested 2 days ago. I didn't know what to say.
This spring, as the coronavirus pandemic heated up, I began to wonder what would happen with Wisconsin's spring primary. It never occurred to me that our state would actually risk people's health by holding an in-person election during a pandemic, particularly when safer alternatives were available.
COVID-19 has made it harder to vote in safe and healthy ways, particularly in communities of color where we see those most impacted by failed healthcare policy.
And that's not why I went into medicine. That's not why I became a pediatrician. I didn't do this to experience countless stories of how policy continues to fail children, particularly children of color.
But providers like me, we can do something small but powerful to ensure that our colleagues and our patients have a seat at the table.
We've created the Healthy Democracy Kit to help you do exactly that. The Healthy Democracy Kit consists of a Vote ER lanyard and badge backer that you can make a part of your regular ID cards. The badge backer that you will receive displays a QR code along with a text code that will direct patients to a nonpartisan online voter registration portal that's specific to their state of residence.
In our Vote ER Healthy Democracy work, we have a few core beliefs. We believe that empowered voices in communities lead to positive health outcomes. We believe that by voting for our health, we can preserve what works or demand change for the things that don't. We believe that our healthcare system is stronger when we, as providers and as patients, all show up.
Doctor, what's that badge?
This badge allows you to register to vote on your own phone. All you have to do is shoot your phone at this QR code or send this text message to this number, and the platform walks you through all the steps to get registered to vote or request your mail-in ballot in 90 seconds. I gotta go see another patient, but the platform will walk you through the rest. Okay.
Of course I'll register to vote, but who are you voting for?
I'm voting for you and your health.
With all that's going on with COVID, I really want to make sure that you can vote in the safest and healthiest way possible. And the best way to do that would be to vote from home. I can help get your vote from home ballot while you're here in my office today.
Every time I feel like it's Groundhog Day, from now on, I'll ask my next patient, are you ready to vote?
As healthcare providers, we cannot tear down these barriers to equity by any one prescription or procedure. We know the limits of our reach. We also know the power of a vote.
Watching all of the drama surrounding this election unfold made clear that we must begin preparing for the November election now.
So vote.
Vote.
Vote like our health depends on it.
Vote like our health depends on it.
And so I hope that that gave you a little bit of background. I know that the video is a little choppy. So to summarize what that work is all about is helping providers get their patients registered to vote. This is what we call a Healthy Democracy Kit badge backer. And basically providers all across the country have been helping to get their patients registered to vote while they're waiting in healthcare settings. This is the lanyard, which providers wear. And long story short, we're seeing a really interesting shift in consciousness among physicians across the country towards this idea of, well, yes, I can help patients sort of in the short term and help put the Band-Aid over the sort of problem at the moment, but to actually help create structural and systemic change, I've got to help empower folks to vote. And this is the last piece I'll end with here. What has been most fascinating as a physician, as a Black man in this country, is that this is the day that George Floyd was killed on May 25th. This is when the George Floyd protests started. Since that time, we have seen a sustained and almost exponential growth of the amount of orders and physicians who are caring about taking this step into the structural dimension and helping their patients by registering to vote. You can learn more at these websites. This is the Vote ER email, and you can follow us on Twitter and Instagram. And then lastly, we'd love all of the sort of cognitive support or sort of administrative support that folks are interested in. If you're interested in this work and you want to hear more and you want to figure out how to help, you can email me, or if you want to directly support, you can use that QR code there. So I hope this was interesting, and I'm going to pass it back over to our wonderful moderators. Thank you.
Thank you, Alister, and thank you to all of our speakers. I appreciate everyone's perspective, and I'm happy that you all were able to join us. Just some housekeeping before we continue. Everyone can feel free to submit their questions using the Q&A feature on Zoom. So please feel free to submit any questions that you have in response to what was already shared. And we had a question sent to us beforehand, and it says, we know that the COVID-19 vaccination tests are ongoing. Are you aware of any preliminary data about the participation of the Black community in these tests?
I think the silence suggests no.
Yeah, I can.
Maybe we could look it up, the data, but
I'm not aware. I'm also not an expert in sort of the vaccination protocols. I am worried, though, about the equitable distribution of a vaccine when it arrives. I think we already saw that with regard to the testing, who got tested and who did not get tested up front when there was a limited number of tests. We have already demonstrated that the system, if we are not careful, can disproportionately select against communities of color. And so I wonder what folks are doing on that front to build in sort of safety mechanisms to think about how to equitably distribute the vaccines if and when it's ready. And that also goes for the treatments, I will say, if and when.
There are conversations underway about the distribution of vaccines with an equity focus. So, I mean, the same kinds of issues that you brought up around the concerns around the biases in terms of who is going to get ventilators, et cetera, are already being articulated, and the concerns are expressed in terms of what is meant about the reasons. And I think a really important framing is not to say that patients distrust the healthcare system. The healthcare system has given very good reasons for patients to distrust it. So I think that it's a matter of not trying to have a orientation to who's going to get a vaccine, which is where a lot of the conventional literature goes about will they be trusting enough to go and seek the vaccine, but rather to have it reframed as a conversation, what will the health institutions do to gain the trust of people to actually distribute the vaccine and distribute it well and equitably.
Just to follow up on that, Nancy, do you have any insights into ways in which we, as a research community and as a healthcare community, can better partner with the Black community so that we can improve participation in research studies? Because my concern is, you know, there's so many times in which we are excluded from the research in and of itself, and the data sets seem to be skewed. So how are we going to sort of effectively create these treatments and, you know, have a vaccine that works for everyone if they aren't part of the research beforehand?
I mean, you're asking a very good question and a very packed question. There's a lot of different components to that. So I think that first, I mean, principles of genuine engagement and partnership, not just inviting people in, but actually listening and having a true participatory structure. That's one whole set of discussions, which is not simply logistical. It's actually based on fundamental principles, starting with minimally Black Lives Matters and also dignity and respect. But I think that there's a deeper part, which is that it's not as if it's also the research community should partner with them. Them is often part of us. And the questions are what's happening with those voices and that leadership, and not making those kinds of dichotomies. But the deeper part, I think, is that for me, as someone who is a professor in public health, and I teach my students very much the history of public health and the history of medicine, and as part of being able to do my work now in the present. And so I think that what is a fundamental part is there's a lot of self-study that needs to happen in the research and medical communities around the histories of scientific racism, and also the histories that go back to times of abolition as well, of those who have resisted that, including Rebecca Crumpler, who was here, was the first African-American physician who was a woman. And she came back here in Boston, then she went to the Deep South again after the end of the Civil War to practice medicine. There are many who you can recount who have had these arguments and these discussions, and to have the humility and understand that these debates about the reasons for inequities have gone on for centuries now, and that each and every one of us in each and every generation need to step up and understand what's at stake. So I think that before just reaching out to quote unquote partner, it's important to do a bit of self-study. And there is a lot of reference literature available that people can read to start to get this history, because I personally think that everyone is capable of learning. That's my premise as an instructor. That's my premise as a teacher. Everyone can learn. There are life experiences and there's expertise, and they both matter deeply. And I have had to learn a lot of history of this country, and I can read, other people can read. That's really important. And that's fundamental to doing science, is actually having an evidence base and a deeply grounded understanding of what the issues are, and not just walking in and thinking that only the latest technological knowledge is what's needed to make a change. It's not.
Thank you. I really appreciate that, Nancy. So we have another question from the audience asking about the crisis standards of care protocol. So I'll turn this to you, Alister. And they asked, what was the reasoning behind deprioritizing ventilators for people with a history of chronic disease, given that chronic disease is a predictor of higher mortality in COVID patients? Were they trying to cut their losses? It seems like the kind of rationale operative in insurance.
It's a great question. the rationale is still not entirely clear to me, to be totally honest. I can speculate, but I'd rather not. I think that what is more an issue here is that if you don't start these kind of conversations with health equity from the beginning, you get in trouble. This idea of how we can equitably distribute in a fair way resources like tests and like ventilators, critical care resources, and vaccines, if you create the protocol and then at the end think about, well, let's now run this through the racial and historical sort of health equity lens, it's too late. And so one of the main takeaways from our experience here in Boston, helping to change the guidelines at the state level, was that we need to have from the outset in these discussions a community participatory process. And we need to have folks involved in the construction creation of these kinds of guidelines and protocols up front that include the voices of Black and Brown people. Because we already know of the disproportionate impact that communities of color face with regard to healthcare because of the social determinants of health, because of structural racism, et cetera. And so, and it's not just about mere tokenism. It's not about having one person on the list of 17 people who are helping to create this. It has to be done in a substantive way. And so that is, I think, my larger takeaway from this. And I hope something that we've learned here in Massachusetts.
I think that we have time for maybe one more response. And I saw you nodding your head, Adrianne, while Alister was talking. So I'm just wondering if you have anything to add, because I'm sure that your perspective as a scientist is very important as well.
Yeah, no, I think that what I've noticed is that it just so well, I don't think it's a coincidence that the people who are most affected during this pandemic are also the people who are least protected. I went to the store during the early shopping hours one time, or the first time I went. It happened actually on 5 different occasions, and I was stopped at the entrance while I saw other people, young people, walking into the store during the early morning shopping hours, and I was stopped and told that these early morning shopping hours were just for senior citizens. And so because I went back to the store, and it happened repeatedly, actually 5 different times, I actually searched for the public health order requiring these early morning shopping hours. And actually in Massachusetts, the public health order only required stores to offer early morning shopping to senior citizens. It didn't, the order did not include other physically vulnerable populations. And so people with underlying health conditions who are more susceptible to severe disease are not protected by this order. And I think it it goes along what I was saying before, that I just think maybe these populations have been invisible because we're not present, we're not at the table when these decisions are made, and so we've just mostly been invisible.
Thank you everyone for participating in today's Global Health Coffee Break. I just want to be mindful of time since I know everyone is busy. And thank you specifically to Nancy, Adrianne, and Alister. I really appreciated hearing your perspectives and appreciated you joining us today. And I also want to shout out the upcoming global health events. On July 9th, we have a Global Health Coffee Break on COVID-19 and public health and impact on non-communicable diseases in Mexico with the Sigma collaborators. And on July 23rd, we have the perspective from the Africa CDC. Hope to see you there. Thank you again.